Does anybody want to help define the difference between type 1 and type 2 diabetes?
Type 1 is you don't make insulin, and type 2 is an insensitivity and usually have higher levels.
That's exactly right. So patients with type 1 diabetes have autoimmune destruction of the cells in the pancreas that make insulin. They're called the beta cells. So they have an inability to make insulin. Traditionally, type 1s have been thought of as younger patients. So when you hear of the old-fashioned term juvenile onset diabetes, that's type 1 diabetes. It can present in adulthood, though, and we're, of course, having problems with obesity in childhood now, so some children are now getting type 2 diabetes. But traditionally, a type 1 diabetic is someone who is thin. They may present with weight loss or thirst, or they could present in diabetic ketoacidosis, where they present with an acidosis due to a lack of insulin. A type 2 diabetic tends to have more insulin resistance. They tend to be, it tends to be more familial than type 1, actually, and it runs in families. It also is associated with obesity and is greatly associated with our obesity epidemic. The pathophysiology that happens with type 2 diabetes is that patients develop hyperinsulinemia. Their pancreas makes more and more and more insulin, and then ultimately the pancreas can't keep up. The pancreas can't make enough extra insulin to counter out their insulin resistance, and it fails and they develop high glucose levels. We'll mostly be dealing with type 2 diabetics during this protocol, and we'll mostly be dealing with the titration of their long-acting insulin. So let's run through the different types of insulins. I think it's very confusing that there's a Humulin and a Novolin and Novolog and a Novolin and Humalog out there. So I think that we should talk about what those different insulins are. So there are long-acting insulins. They have profiles where they either act for 12 or 24 hours. The one that we use here the most is going to be Lantus. And we traditionally think of Lantus as a steady insulin that lasts for 24 hours. NPH insulin is a 12-hour insulin in our mind. It kind of peaks after 6 hours and has maximum effect after about 6 to 8 hours. And then its work is complete after 12 hours and it's out of the system. And then Levemir insulin is considered continuous flat insulin like Lantus, but it probably peaks after 18 to 20 hours. We don't have Levemir here that I'm aware of. Lantus is frequently a once-a-day insulin, and we consider that it doesn't peak. It doesn't have any times when it has a maximal effect. A time when it peaks or has a maximal effect may be a time of low glucoses or hypoglycemia. NPH does peak at about 6 to 8 hours and can cause hypoglycemia at that time of the day depending on what else is going on. And Levemir is essentially considered a non-peaking insulin. NPH is sometimes, here I think it's best to just call it N-insulin or NPH insulin. I think that's clearest. When you're out practicing, it is sometimes called Humulin N or Novolin N, and whenever anybody says that N on the end, they mean NPH. The short-acting insulins are listed here. Regular is one that we see frequently and is readily available here. Regular acts for probably about 6 hours. It peaks probably about 3 hours, and it's used for a short period of time to act at meals. Humalog, Novolog, and Apitra I think of as copycat insulins. They all essentially behave the same way, and they peak quickly after just a couple hours. So we frequently in the hospital will talk about the use of basal bolus insulin. Does anybody know what that term means?
You have a baseline level, and then there's like little peaks or boluses throughout the day.
Exactly. So that's exactly what we mean. So normally, the pancreas continuously secretes insulin throughout the day. And that's the basal insulin that's continuous throughout the day. And then when you eat a meal, your pancreas makes more insulin, and that's the peaks that you're talking about. We call it the mealtime insulin or the bolus insulin. So we try to mimic what the pancreas normally does when we prescribe insulin to patients. And so we provide basal insulin, which is a long-acting insulin, to provide continuous insulin coverage throughout the day, just like the pancreas would continuously make insulin. Then we provide bolus, or meal insulin, which is short-acting insulins, in order to provide the extra insulin that pancreas would make in response to a meal. Sorry, that's my phone, but it's okay. So the insulins that we will be titrating the most here will be the basal insulins, but I think it's important for you to understand the activity of the bolus insulin in case a patient's on it, so that you can understand where a problem may be if they're having high or low sugars. So we just talked about this, but what is the role of basal or long-acting insulin? And how do you know if the basal dose is adequate? So like we just said, the role of the basal long-acting insulin is to provide continuous insulin throughout the day. And do you all know, how do you know if the basal dose is adequate?
Morning glucose.
Right. So a basal insulin helps control fasting, can be monitored by knowing what their fasting glucoses are. So if their fasting morning glucoses are high, you need more basal insulin. If they're low, or they're having lows overnight when they're fasting, then you need less basal insulin. So I think we've hit this too, but what is the role of bolus short-acting insulin? It is mealtime insulin to provide insulin where the pancreas would normally make some for meals. And you know if this is adequate if the sugar is normal at 3 or 4 hours after a meal. And you know that it's inadequate if a patient has sugars that rise throughout the day. So if they start with a sugar of 100 in the morning, and then their sugar's 150, 190, 220, they didn't get enough insulin with their meals, and their sugar's going higher throughout the day. What are some complications of hyperglycemia? Can you guys throw some out? There are lots.
Diabetic ketoacidosis.
Exactly. So that's one that we worry about, and it's a severe problem in patients with type 1 diabetes. DKA is when they're absolutely void of insulin, and they get a ketoacidosis in response to their body being unable to process glucose properly. So that's absolutely one huge complication of hyperglycemia. And the most important thing that I could teach you about that is that type 1 diabetics can never go without insulin, or they will develop DKA. It's a problem we frequently encounter in the hospital, that a surgeon will inappropriately advise a type 1 diabetic to hold their insulin when they're in PO, and you cannot do that. They always require insulin, and if you could take that into your internships, it would be a huge, huge success. What are some other complications of hyperglycemia?
Diabetic coma with type 2 diabetes.
Exactly. So a diabetic coma frequently, or hyperosmotic hyperglycemia frequently occurs when someone with type 2 becomes incredibly dehydrated, and it tends to be less of an insulin defect problem, which DKA is, and more of a huge dehydration from the glucose load. So that can occur as well. Other complications from hyperglycemia? And you can, I'm thinking long-term ones as well.
Neuropathy.
Exactly. So we think of microvascular complications, or complications of small vessels. And the ones we frequently think of are problems with the eyes, or retinopathy, where there's problems with blood vessels in the back of the eyes. Nephropathy, or small vessel damage to the kidneys, that frequently presents with protein in the urine, which is measured as microalbuminuria, or an increased amount of microalbumin to creatinine in the urine. And then the other microvascular complication that we think of is neuropathy.